During this class, I'll be basically discussing about bronchial asthma, some of the basics of bronchial asthma, some definitions and the new updates which are there, and something which will be useful for you in clinical practice as well. So as we all know, asthma is one of the most common cases which comes to a casualty or a medicine ward or a pulmonology ward. So there are a lot of different steps in which everyone manages bronchial asthma. But let us take a stepwise approach on how to manage bronchial asthma. And before that, understand the basic pathogenesis of bronchial asthma. What is bronchial asthma? What are the pathogenesis which are associated with bronchial asthma, and what are the differences in treatment that can be done depending on the different phenotypes of bronchial asthma? Because every asthma is not same. There is something which is most of us are familiar with allergic asthma. There's something which is there's something known as non-allergic asthma, which is also becoming quite common nowadays. Okay, so I'll be dealing it in different headings. Firstly, I'll be talking about the definition of bronchial asthma, pathogenesis and phenotyping of bronchial asthma, clinical features, and treatment. I will be discussing, I won't be discussing the drugs in details, but I'll be telling you what is the treatment as per the GINA guidelines, which came up in 2021, and assessment of treatment, like how to assess whether you are giving the adequate treatment or not. Then something called a severe asthma and the use of biologics in bronchial asthma, which is relatively a newer topic. So firstly, what is asthma? As we know, asthma is the most common chronic non-communicable disease, and it affects over 260 million people globally in 2019. And before moving further, the class is based on Harrison 20th edition, Fishman Disease of Pulmonary Textbook of Pulmonary Medicine, Murray and Adams Textbook of Pulmonary Medicine, and GINA 2021 guidelines. So it's a mixture of all those. I've taken a little from everything, but it's mostly a pulmonology textbook based class. So whenever you are asked to define asthma, um, you can't just say that it's an inflammation of the airways. There are something in addition to the definite pathogenesis of asthma. So asthma is a heterogeneous disease, and it is usually characterized by chronic airway inflammation. And it is defined by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Now, if such a definition is difficult to by heart, just keep your focus on whatever is shown in red color, whatever I marked as red. So asthma is a heterogeneous disease. Secondly, as we all know, it is characterized by chronic airway inflammation. Then thirdly, what are the symptoms of asthma? There is wheeze or rhonchi or auscultation. There is shortness of breath. There is chest tightness and cough. And most important point to be noted here is it varies over time and intensity. That means an asthmatic will not be symptomatic throughout the year. There might be factors which will exacerbate a patient's symptoms. There might be factors which worsens a patient's symptoms. And this is something which differentiates asthma from COPD. COPD is something as when you expand COPD, it comes as chronic obstructive pulmonary disease. So it is something which is a progressive condition. And patients with COPD usually have symptoms of cough with expectoration, breathlessness, which are present throughout the year. Asthma, the most important point to be noted is there is something called as a symptom-free interval. The symptom-free interval is one of the most common features of bronchial asthma, and that is something which differentiates it from COPD. And the other thing which has to be noticed here is there's something called as a variable expiratory airflow limitation. This variable expiratory airflow limitation is one of the most common clinical characteristics of bronchial asthma, which helps it in differentiating from COPD as well. So in COPD, there is something called as a fixed expiratory airflow limitation. Asthma, it's normally a variable expiratory airflow limitation in general, but there are some cases in which there can be fixed expiratory airflow limitation, but that in itself is a different phenotype. And as I told, the third point, the airflow limitation may later become persistent, but that is seen only in a smaller percentage of individuals. So this definition has been taken from GINA 2021 guidelines. So always remember, it's a chronic inflammatory condition and the symptoms vary over time and intensity, and it has a variable expiratory airflow limitation. Now, what are the clinical phenotypes? As we are discussing about bronchial asthma, there are different, most of us are aware of something called as allergic asthma. Basically, if you have allergy or symptoms of allergy right from childhood, it may progress to asthma, or the first presentation of an allergic condition might be asthma. But here we are discussing about the clinical phenotypes. That is, one is allergic asthma, in which you have predominantly a eosinophilic mediator. That is, it's mediated from eosinophil allergic mediators like interleukin 5, interleukin 4, and interleukin 13. Then there's a non-allergic or non-atopic asthma, in which this asthma can be either induced due to a chemical irritant or due to a viral infection. So that can be either, it consists of a neutrophil or an eosinophil, or it can be paucicellular. Paucicellular means it's a combination of inflammatory cells, but predominantly a neutrophilic predominance might be seen. The other is an adult onset asthma, and this adult onset asthma is mostly seen in females and in the elderly. Then obesity related, and asthma with persistent airflow limitation, which is a rare form. So these are something which are clinical phenotype based on the clinical conditions and based on the clinical symptomatology of the patients. We can differentiate into different types. Earlier, as we all know, as we might have read in our patho books or general medicine textbooks, there's something called as an intrinsic asthma and an extrinsic asthma. But nowadays, this is more useful. This classification, whichever I have seen, is more useful, not just in classifying the patients, but it also helps in treating the patients as well. Now, what are the clinical symptoms of asthma? As we have seen in the definition, it mainly consists of symptoms of wheeze, shortness of breath, and cough or chest tightness. And as I told already, it varies in time and intensity. Patient will have symptom-free interval in between. So that is the main differentiating point between asthma and COPD. So as the various points are there, the patients can experience more than one of these types of symptoms. The symptoms are often worse at night or in the early morning. Symptoms vary over time and intensity, and there are various triggering factors. That's what I told. The patients wouldn't be symptomatic throughout the year. There are triggering factors like viral infections, exercise, allergen exposure, changes in the weather, or in children, it can be provoked by laughter, or irritants such as car exhaust fumes, smoke, or strong smells. So the following, now, when do you say that it is less likely to be an asthma? So whenever the patient comes, he gives you the history, and now it's up to you to decide whether it's an asthma or a COPD. Now, why do you want to differentiate? Because the treatment protocols are completely different. In asthma, you may mainly go with steroids, right? It's mainly an anti-inflammatory treatment. You give it the inhaled steroids and long-acting beta agonist. But when you go into COPD, steroids are seen only in a very, very late stage when your treatment is not controlled with a muscarinic antagonist and a beta agonist. So that is one thing which you should always remember. You can't blindly prescribe an inhaler without knowing what the diagnosis is, because in COPD, if you give a steroid inhaler, there's always a chance that he can end up in having pneumonia, bacterial pneumonias, and other exacerbations. So what are the features which decrease the probability that the respiratory symptoms are due to asthma? If there's an isolated cough with no other respiratory symptoms, chronic production of sputum. This is more seen in COPD and bronchiectasis when there is a chronic mucoid expectoration of sputum. Now, there's a shortness of breath associated with dizziness, lightheadedness, or peripheral tingling, more of a systemic condition, and chest pain. So, chest pain is very rare in asthma unless it's a cardiac condition which has developed an asthma at a later date. Now, when you're coming to basic pathogenesis of asthma, there's some 2 points which I want to discuss. This is something which is always asked as well. One is known as the hygiene hypothesis, and the other is known as allergic march. Now, what does hygiene hypothesis state? Hygiene hypothesis states that if you have a chance, like if you're in your childhood, if you are exposed to infections, there is a particular protections against allergic disease at a later date. Now, the problem with nowadays are we are more prone to cleanliness. I'm not saying that cleanliness is bad, but too much of cleanliness means the child is not exposed to any allergen or exposed to any infections. So because of that, there's something called as a phenotypic switching which takes place. So usually whenever you get an infection, the Th2 will get switched over to Th1. And when this switching over doesn't take place, the child gets prone to asthma at a later date. So basically, the thing is, if you get infections in childhood, you will get a immunity which is developed, and this immunity will help you in the future. So That is what it states. The early childhood exposure to particular organism protects against allergic disease, but contributing to the development of the immune system. Basically, as we know, most of the allergic asthma is due to a Th2 phenotype, and this is mainly because you have been not exposed to any infections in a younger age. And second is something called as allergic march, and this is another state in which you see that the allergy usually progresses from childhood. Your antibodies start developed even from an antenatal period of time or a perinatal period of time. Your initial manifest, but at a later date keeps on progressing. The initial thing, moreover, studies have shown that initial allergy a child or an infant might develop into the egg protein as well as the cow's milk. Hence, egg protein and the cow's milk. So this will be the initial allergen or the initial allergic response which will be produced. It will later progress to an allergic dermatitis or atopic dermatitis, allergic rhinitis, and allergic asthma. So usually in child or an age group of 1 to 3 years, it's more of an atopic dermatitis and an allergic rhinitis kind of picture, but that in turn might progress to asthma on a later date. And in some cases, it might be such that it might even regress. That means he will be symptomatic, really symptomatic during his childhood. He will have excessive of symptoms, excessive of exacerbations, excessive admissions. But on a later date, the child will revert back to the a non or asymptomatic stage. So it's a natural history of atopic manifestation, which is characterized by typical sequence immunoglobulin antibody response, and which may appear earlier in life, persist over years or decade, and often remit spontaneously with age. That is, he may progress from atopic dermatitis to a allergic rhinitis and allergic asthma. Later, he might regress or remit spontaneously with age. So this is what I told. Allergic march, initially it starts with an eczema. So even before eczema, there is something called, as I told, there will be allergy to the egg protein as well as the cow's milk protein. It will later progress to eczema, which will progress to a food allergy, rhinitis, and finally it will result in an asthma. So this typically happens over a sequence of years. If you look at the x-axis, there is birth. Around 3 to 1 year, it will be mostly an asthma. Then it's a food allergy. This can be, it can be either way around. Either initially it can be food allergy progressing to a dermatitis, or the other way, eczema, food allergy, rhinitis, and asthma. About 30 to 50 or around 40 to 60 percentage of individuals with allergic rhinitis will always have a chance to progress to allergic asthma, which has to be noted. So these are two things which I just wanted to put a word out, because this is something which is normally asked either in vivas or as a normal question, or even in a university as a short answer question, or maybe even in MCQs. So now coming to the basic pathogenesis of asthma. So as I told, there is something called as an allergic asthma and a non-allergic asthma. Or nowadays the terminology has been completely changed. It is either a Th2 high asthma, which is your allergic asthma, or a Th2 low asthma, which is your non-allergic asthma. So what happens? So whatever we say, like allergic asthma is more of a Th2 type, that is Th2 high, and this is something called as Th2 low. The basic point to be noted here is, it's very important to identify the phenotype if the asthma is uncontrolled, because the treatment of this phenotype, the Th2 type, the Th2 high phenotype, and the Th2 low phenotype is completely different. And another important point to notice here is there are various markers like interleukin 4, interleukin 5, and there are mainly targeted therapies which will be useful later in a severe asthma case. I'll be discussing that in later. So firstly, what happens is, all this, whenever you have an allergy, whenever you have allergen, or whatever you say, whenever you have exacerbation, whenever you have some cow protein, some proteins or pollens, whatever is causing the allergy. So as we all know, whenever an allergen enters into the body, it is taken up by the dendritic cell. The dendritic cell is the presenting cell. So then it goes into it is taken up by the dendritic cell and these are the antigen presenting cells which present it to the Th0 lymphocytes. Now the Th0 cells can differentiate either into Th2 or a Th1. Now if it goes into a Th2 response or an allergic response, there are various mediators which are released. One is interleukin 4, interleukin 5, and interleukin 13. So these are the main things The entire pathogenesis is a complex process, but just remember interleukin 4, interleukin 13, interleukin 5. So, and these are the main mediators in an allergic asthma. Now, the non-allergic asthma, as I told, it's more of from a neutrophilic predominance. That is, it's more of due to a viral infection. So, whenever you have a viral infection, the Th1 response is activated. It activates the neutrophils, and there are various mediators like CXCR1 and CXCR2 and the Th17 or the interleukin 17 or CXCL8, which is the main cause of asthma, or which is the main cause of airway hyperresponsiveness. So as we all know, in asthma, what happens is your airways get, the airways get narrowed off. This narrowing of the airways is due to a bronchoconstriction. This bronchoconstriction is brought about due to airway hyperresponsiveness. As we all know, you have a airway smooth muscles which are there. Whenever you take the normal anatomy of bronchi, there's something called as a airway smooth muscles. These airway smooth muscles, whenever there's an allergen or due to the release of these various mediators by the eosinophils and the mast cells, because of these release of the mediators, there is hypertrophy of the airway smooth muscles. And whenever there is an hypertrophy of the airway smooth muscles, the airway gets narrowed. And because of this airway narrowing, the symptoms of asthma are produced like wheezing, cough, breathlessness, etc. So the important point to note here is this is the current pathogenesis of bronchial asthma. If someone asks you, there's a type 2 inflammatory type and non-type 2 inflammatory type. If it's a type 2 inflammation, it's called as a Th2 high. And if it's not a type 2, it's called as a Th2 low inflammation. So as I told, if you see here in this type 2 inflammation, you have an allergen. It can be anything. It can be proteins, pollens, a dust mite, whatever it is, or a drug. This allergen acts on the airway epithelium because of the, and as I know, there is a dendritic cell which is present. This presents it to the THO cell, the TH0 cells. This T regulatory or the TH0 cells will activate the TH2 cells, that will in turn activate the mediators like interleukin 4, interleukin 5, and interleukin 13. Now, as we all know, these are the mediators which causes the bronchoconstriction. There is a release of fibroblast. There are other mediators as well, like periostin, which are released from the airway epithelium. All of these will cause a basement membrane thickening, a smooth muscle hypertrophy, and all of this in turn will go into a airway constriction or a bronchus constriction. And this in turn will result in bronchial asthma, the symptoms of bronchial asthma. Now, what happens in non-type 2 inflammation? Non-type 2 inflammation, as I told, is mostly due to a cigarette smoke, pollutants, or rarely a viral infection. Here, the macrophages or dendritic cells, the epithelium, it gets damaged. Whenever there's an epithelial injury, the macrophages or dendritic cells gets activated. The T helper cells or the Th0 cells get differentiated into two types. One is Th1 and the Th17. Now here what happens is there's hyperplasia, hypertrophy, and airway hyperresponsiveness. In this also the mast cells are regulated, but there is no role of eosinophils here. There you have an in IgE, the serum IgE, and which is released as a part of interleukin 4 and interleukin 13. And here you have eosinophils from interleukin 5. But here, because of the Th1 cells activated and Th17 cells activated, there is something called as because the neutrophil is released. And here there is more of a goblet cell metaplasia and mucus hyperprotection. And this in turn will result in severe asthma. Many a times what happens is, usually you are allergic to something. So on top of that, if you have a cigarette smoking or if you're exposed to too much of air pollution, like we are seeing in the cities nowadays, there are multiple mechanisms which act, right? So you have a mechanism which is going to interleukin 4, 5, 13, your serum IgE and your eosinophils. And here you have something which is called, which is acting through neutrophils. So there are some important points which I will tell you, which will make it easier. Whenever you are talking about a Th2 high asthma, always remember interleukin 4, interleukin 5, interleukin 13, and interleukin 33. And there's something called, which are the major features of a type 2 asthma. And when you're saying a type 1 asthma, always remember there is interleukin 17, CXCR1, CXCR2, and CXCL8. So these are the most important points which are to be noticed. And one thing I want to change here is this Th2, the low asthma. TSLP is a part of Th2 high asthma. Sorry, it's my mistake. There's something to be edited here. TSLP is a part of TH2 high asthma. It's not a part of TH2 low asthma. Now, and why should you know about all these mediators or interleukins? I know it's difficult to remember. Thing is, whenever you go to a severe asthma and whenever you are going to treat a severe asthma cases, all these interleukins are important because there are targeted therapies, which are some of them are already FDA approved. The later things are in studies towards this targeted therapy, because whenever earlier oral corticosteroids was your, along with the inhaled corticosteroids and the LABA inhaler, was a mainstay of treatment in asthma. But nowadays, even if the asthma is uncontrolled with that, you have to look for other options as well. So that is where this comes in. So as I told, asthma is characterized by airway hyperresponsiveness. There is a basement membrane or an epithelial thickening. There is mucus hypersecretion. There is goblet cell hyperplasia, and mainly involves a medium-sized bronchi. So that the word in itself is bronchial asthma. So it mainly involves a medium-sized bronchi. But nowadays there are studies which are show that asthma has a small airway involvement as well. So that is something which is always controversial. We always say it's a medium-sized bronchi, but there are a lot many cases when you enter clinical practices which are small airway involvement or there's a mixed pattern. So the basic pathogenesis which you have to remember is there is a, as I told, there is there is a basement membrane thickening or epithelial membrane thickening. There is mucus hypersecretion mainly due to neutrophils releasing interleukin 8. There's a goblet cell hyperplasia. It mainly involves a medium-sized bronchi and the query of small airway involvement. So this is what happens. This is your normal airway. And this is your asthmatic airway. As we know, there is a bronchoconstriction which is occurring. So as I told initially, there's a smooth muscle hypertrophy. That is the first point. So if someone asks you what are the major pathogenesis of asthma, you can say it's allergic and non-allergic. What are the various changes which happens in the medium-sized bronchi or in the airway? There is smooth muscle spasm or smooth muscle hypertrophy. There is mucus hypersecretion. There is goblet cell hyperplasia and then eosinophilic inflammation. So the mucus hypersecretion or goblet cell hyperplasia caused mostly by interleukin 13 as well as by interleukin 8. And smooth muscle spasm is caused by interleukin 4. Eosinophilic inflammation is through interleukin 5. So it's eosinophil, serum IgE, interleukin 4, 5, 13, interleukin 17, interleukin 33. Now, what are the predisposing asthma? As I told, there are various factors which can cause asthma. Can all of us have asthma? No. There is something which are predisposing it. Allergy or atopy, a family history of allergy, a family history of atopy, or if the child, as I told, allergic asthma or allergic march, right from childhood, if he has allergic manifestations, allergic to cow proteins, allergic to egg proteins, etc., cow milk proteins, egg proteins, etc., he is prone to develop asthma. Second is viral infection. Viral infection in itself can cause an epithelial cell injury, really, resulting in release of inflammatory mediators, which can result in asthma. Then there are several genes which have been told in hereditary factors, OMDRL3 and ADAM33 mutation. So always remember this. This is just for a knowledge point of view. There's not much of genetic analysis which you go into asthma. Whenever you get an asthma patient, you just treat the patient. Dietary factors, yes, there is something. There are now supportive studies which are showed dietary factors have an important point in predisposing you to asthma. Vitamin D deficiency can result in asthma. Omega-3 fatty acids are protective in asthma, but if you are saturated fatty acid, omega-6 fatty acids are more in use. There's always a chance that you can have asthma. Then air pollution and environmental pollution, which is the most common cause of asthma nowadays. And it's not just, it's a it can exacerbate even a stable asthma. And it can also cause COPD as well. One of the most common causes of COPD nowadays is air pollution. Then smoking, as I told, smoking in itself can cause a neutrophilic, which is a non-TH2, non-allergic form of asthma because of the release of interleukin 8. Then there are drug-induced asthma as well, mainly aspirin-induced NSAID, COX-1 inhibitors. So in such patients, we should always prefer a selective COX-2 inhibitor. And exercise. Why does exercise cause asthma is always a question. Exercise causes a drying of your epithelium. So because of this drying and because of the lack of mucus, there can be release of inflammatory mediators which can result in asthma. Now, symptomatology, I've already told you, cough, breathlessness, wheezing, and chest tightness vary over time. Symptom-free periods are usually present. It worsens at night and early morning hours. Now, how to diagnose? Now, the main point here is whenever you are trying to diagnose a case of bronchial asthma, a lot of things, a majority of your factors, your what do you say, your spirometry or a pulmonary function test and your other tests are just a supportive factor. Your main thing is your history taking. When was the onset? What are the factors which are caused in this? Whether there is a family history of that, whether he had fever, especially when you're seeing in a child, if the child is less than 3 years and if it's a viral infection, you should always try to see whether the wheezing is due to viral infection or it is the beginning of asthma. It's a tricky scenario there because in viral infections can cause bronchiolitis, which in turn can result in wheezing. So, but then you have to see whether it's a transient wheeze or a persistent wheeze, especially in children, to diagnose whether it's an asthma. So spirometry is just a confirmation, but sometimes what happens is that your spirometry may in turn to be normal, but you still have a history which is highly suggestive of asthma, like family, there's a family history of asthma, your symptoms are more prone to asthma, your symptom free intervals in between, you don't have a cough with expectoration. So in such cases, it's always a tricky scenario whether to treat him as a case of bronchial asthma or not. But in most of the cases, it's better to treat if you have clinical features which are suggestive of asthma and which are varying in intensity over time and duration. It's better to treat him as a case of asthma. So as I told, history taking is most important in diagnosis of asthma. Always see whether there is a respiratory symptoms since childhood, whether he has allergic rhinitis, allergic eczema, basically the allergic march which I was talking about, whether he has a family history of asthma or allergy. That increases the probability that the respiratory symptoms are due to asthma and not specific for asthma and not seen in all specific asthma phenotypes. So something that's what family history may not be always there. So that is something anyone can be the first generation who is having an asthma. So physical examination, most important point to note here is asthma is not like pneumonia. You won't be getting crepitations or anything. Most often times there are no other systemic findings which you will be able to see unless the patient is in a severe exacerbation. Often it is normal. The thing is he will have findings only earlier bilateral polyphonic wheeze or an expiratory wheeze will be mostly seen only in exacerbation. Only in a severe asthma case he will be having persistent wheeze. And whenever you have persistent wheeze, we have to look into other factors as well, other contributory factor, whether he has COPD and stuff like that. So most of the cases it's often normal. There will be expiratory wheezing on auscultation, but this may be absent. So always try for a forced expiration. It can be not normal expiration won't be enough. Ask him to take a strong breath in and a forceful expiration. And in end expiratory wheeze, you can there can be some wheezes which you miss out. And if it's a patient is in a severe exacerbation, patient is severely breathless, there's something called a silent chest, in which you won't be able to hear any breath sounds. But all that happens in a severe exacerbation. Mostly the patient will be in casualty, and there will be other factors. He'll have an increased respiratory rate, he'll have a toxic look. And always rule out any allergic rhinitis or nasal polyposis. And always while taking history, ask history of any drug intake, ask history of any occupational exposure, which is always important. And even if it's due to an occupation, ask him whether he has symptoms on the first day of occupation, whether he has symptoms on most days of occupation. In such case, allergen avoidance is very important. So a basic the most important factor in asthma according to me is basically your history taking, because history taking contributes a lot in diagnosis. Whether he has symptom-free intervals, whether this is his first attack, whether he had similar complaints in childhood, whether his family members had similar complaints, whether he has any dermatitis, whether he has any nasal stuffiness, or whether he had any nasal polyps, whether he has a septal deviation. All those are very important while diagnosing a case of asthma. Now, next is the supporting. From here, I'll be talking mainly in whatever has been mentioned in GINA. There's not much of an explanation regarding all this lung function testing in your Harrison's. So from now on, it will be mostly a pulmonology textbook based on the GINA guidelines based. So what you're having is you have these are the parameters you should remember: FEV1, FEV1C, peak expiratory flow. There's something called as bronchodilator reversibility, and there's something called as variability. So this is what I'll be discussing. I'll be discussing in detail by taking into point everything. So the basic thing you have to remember here is a peak expiratory flow and an FEV1 by FVC. So these are the most important factors, and a bronchodilator reversibility. So these are the most important factors which help us in diagnosing a case of bronchial asthma. And as I told, this is just supportive. Your history is the mainstay in diagnosis. So after history of the symptoms are obtained, the next step is to document your airflow limitation. It can be done through spirometry with cross bronchodilator reversibility, a positive bronchial challenge testing, a peak expiratory flow in which you talk about the diurnal variation, a positive exercise challenge test, and improving in lung function after 4 weeks of anti-inflammatory therapy. Now, what is spirometry? As we know, this is what is known as a spirometer graph. So in spirometry, what you actually, many of you would have seen, you ask the patient to take a deep inspiration and ask him to blow out as forcefully as possible and for 6 seconds and take a deep breath in to complete the cycle. So here you have made that these are the main values which you have to see: FEV1, FVC, and FEV1 by FVC. The forced expiratory time is more important in COPD, not in asthma. It's more of a test for COPD. If it's more than 6 seconds, there's high chance the patient has a severe COPD. So here, if you see, so what is this? In what at a time when FEV1, the first finding which you had to see in spirometry is whether he has an FEV1 by FVC which is reduced. And not just that, a FEV1 by FVC reduction is not enough to diagnose a case of bronchial asthma. There should be, then after that, what happens is initially you do a spirometry. And after spirometry, here you see there's something called as a pre-bronchodilator and a post-bronchodilator. This is a pre-bronchodilator, post-bronchodilator. So initially, you take a spirometry as the patient comes in. You have to take a proper history of the patient. And there are some guidelines which have to be followed. And you have to see whether the patient has taken any of those in the last, whether he has smoked, whether he has consumed coffee. So all such factors I'll be discussing later whenever I'm discussing PFT. Here, you have to just remember is there is a increase in FEV1 of greater than 12%. So after that, so initially your initial spirometry is done. Now you give a bronchodilator, and the bronchodilator, it can be either a short-acting beta agonist like salbutamol, 200 to 400 microgram, or an equivalent, and it's compared with the pre-bronchodilator reading. So if after a post bronchodilator, after about 10 minutes after a bronchodilator is given, if you see an increase in FEV1 of greater than 12% and greater than 200 ml, that means it's a diagnosis of asthma. Always remember, it is FEV1, not FEV1 by FVC. It's more than 12% and greater than 200 ml. There is no or, it's greater than 12% and greater than 200 ml. This is always seen in MCQs when they, one of the options will be whether there is increase in FEV1 of greater than 12% or greater than 200 ml. It's not or, it's increase in FEV1 of greater than 12% and greater than 200 ml. And you can say with greater confidence, it's a case of bronchial asthma if the increase is more than 15% and more than 400 ml. And in children, an increase in FEV1 of greater than 12% is enough. So compared with positive test, more likely if the bronchodilator is withheld. Now, if the patient is already on a bronchodilator, like he had visited a doctor, he had given him a bronchodilator, a withholding of bronchodilator is always necessary. If it's a short-acting beta agonist, it should be withheld either at least for 4 hours, minimum of 6 hours. Twice daily, if it's on a LABA like a Formoterol or something, it should be withheld for 24 hours. If it's a LABA, it's a once daily LABA, like the newer LABAs which are come, like Bilantrol and everything, at least for 36 hours, it has to be stopped. So this is what happened. Here we have a patient. Here, if you see, this is the lower limit of normal, 0.68. So earlier we used to say FEV1 by FVC less than 0.7, that's it. But nowadays, because of the height and weight of the patient, the normal values can change. And even based on the ethnicity, the normal value can change. So because of that, we have kept something called as a lower limit of normal. Now, depending on the lower limit of normal is how we differentiate. So here the lower limit of normal is 0.68, which is the normal, but his is only 0.52. His FEV1 is reduced because the lower limit of normal is 2.91. Here FEV1 is only 2.02. FVC is normal. FVC is normal because lower limit of normal is 3.7. So here you have an obstructive pattern. The pattern, the blue color is pre-bronchodilator. So therefore, if you see, this is how it goes. This is typical of, it's called as a dogtailing. It's typical of a obstructive airway pattern. Now, after post-bronchodilator, if you see his FEV1, there's a improvement of 29%. So as we say, as we told, there has to be a change of greater than 12% and 200 ml. Here the ml, here see there's a change of 590 ml, means his FEV1 has improved by 590 ml. So this can be this is a case of bronchial asthma. Here also see the red curve, the second curve which is coming. So initially this is pre-bronchodilator. So after you are given a short-acting beta agonist and taken the pulmonary function test, after 10 minutes, you see there is a improvement in his FEV1. So an improvement in the curve as such, you can see it very clearly in the graph. So that's what. Now there's something called as a peak expiratory flow. This is something which you can, if you are not equipped with a spirometry in your settings, because spirometry machine, although it's available in almost all centers right now, if you are in a primary health center or some other setup like that, there's something called as a peak expiratory flow. This is something which you can buy and keep for yourself. So in this, what happens is you just ask a patient to take a breath and ask her to blow out into the peak expiratory flow meter. And in peak expiratory flow meter, what we have to say is there is no normal value as such. The normal value is depending on the height and weight of the patient. There are charts which are available as well as the sex. There are charts which are available. The charts are readily available on internet. And not just that, many of the peak flow meters are equipped with these lines like red, yellow, and green. Green means it's normal. Yellow means there's some abnormality, and red means its peak expiratory flow is really less. So this is something which you can be used in your OPD basis. Is one value of peak expiratory flow enough to diagnose this as case of bronchial asthma? Not at all. There is something which has to be done called as a diurnal variation. So that means in your morning and evening, if there is an excessive variability in twice daily peak expiratory flow over 2 weeks. So you have to make your peak expiratory flow twice daily over 2 weeks. And if you see a variability, normally in an adult, there's a diurnal variation of less than 10%. If in adult, there is a value, there is a variation in the value of more than 10%. And in children, if there is a variation of value in more than 13%, that is what helps in diagnosis of asthma. If a single reading which goes into red, although it is highly predictive of asthma, as per guidelines, you can't define it as a case of asthma. So you have to always look for the variability in peak expiratory flow measured twice daily over 2 weeks. So this is what you see. Now, the other thing is a bronchial challenge testing. All these things are basically in PFT. If you go into the science of it, there is so many things which has to be discussed, which can be discussed in a bronchial asthma class. So what you have to remember is in bronchial challenge testing is you give increasing dose of something called as a methacholine. Methacholine, as we all know, is a cholinergic. So it will cause bronchoconstriction. And basically, as we know in airway, in bronchial asthma, there's bronchial hyperresponsiveness. So even for small doses, they start responding at a very high rate. So if there is a fall, firstly, what you do is you do a spirometry, you record the FEV1, as I told. And if after giving out the standard doses of either methacholine, if there is a fall in FEV1 greater than or equal to 20%, if there is a fall in FEV1 greater than or equal to 20% from the base, from his baseline FEV1 value, that is known as a positive bronchial challenge, bronchial provocation testing. And there's something called as provocative dose, that is the at which dose of methacholine does the bronchoconstriction occur. And there are values which are there for that. So just remember, if there's a fall in baseline of greater than 20% with standard dose of methacholine, or greater than 15% with standard hyperventilation, hypertonic saline or mannitol challenge, that contributes to asthma. So this is what happens. This is known as a bronchial challenge testing. Here you see, these are the doses of methacholine. So this is how the normal airway response. And this is what happens when you, in an asthmatic, the graph is coming down, right? So this is the provocative dose. At a dose of 0.8 milligram per deciliter, there has been a fall in FEV1. Here you see his FEV1 is around, roughly if you take around 100 to around maybe 90%, 100% roughly. Here you see it's broken down to 80%. That is, there's a fall of more than or equal to 20%. And at a dose of 0.8. In normal people, no matter how much ever you give, that is up to there's a certain limit up to which you can give. Beyond up to that, there won't be any fall in a baseline FEV1 level. Now, the other thing is something which can be tried and tested, in which you see the improvement in lung function. Now, suppose a patient comes to you, you see the patient has bronchial asthma, you give him an inhaler containing a steroid. After 4 weeks, you have to document. You have to document whether there has been a significant improvement in lung function. That means you do a baseline PFT, and after 4 weeks of anti-inflammatory treatment, whatever you have given, LABA, ICS, then you can diagnose a case of bronchial asthma. That is, there's a variation of FEV1 of greater than 12% and greater than 200 ml between visits. Now, these are the other variants of asthma in occupational asthma that I told already. You have to take a proper history, whether he has any occupation exposure to asthma and stuff. Pregnancy. Now, important context with respect to pregnancy. In pregnancy, what happens to bronchial asthma? One third of the cases improve, one third of the cases remain stable, one third of the cases deteriorate. So that is one important point which you have to remember. In pregnancy, one third of the cases improve, one third of the cases remain the same, one third of the cases deteriorate. Then third is obesity, and fourth is a COPD asthma overlap syndrome, which I'll be discussing in detail in COPD. Now suppose you you have a patient, you diagnosed him as asthma, you started him on an inhaler. Now, how to assess him? When is the right time to assess? Now, he should be assessed every 2 to 3 months after treatment initiation. Now, whenever a patient in asthma is coming to you, what are the things which you do? Like, what are the things you assess? You have to assess the symptom control as well as the future risk of adverse outcome. In this, symptom control is most important. Future risk is something which can take off at a later date. If your symptom is not under control, then that is a problem. There's something wrong with your therapy or your dosage has to be increased. But the most important factor to notice is to see whether the candidate is using the inhaler properly. Now, how to assess symptom control? First of all, you have to ask. All these are history take. One is asking the frequency of daytime symptoms, whether the patient has daytime symptoms or nighttime symptoms. How many nighttime awakening? How many times is he using the inhaler at night? Then how many times is he using the reliever medication? Then there's something called as asthma control test and asthma control questionnaire. So all of these are more of a questionnaire type. It's more of asking the patient. There is no lab parameter which is necessary, or there's no spirometer which is necessary. So now the patient has come for follow-up after like you say 1 month. So you obviously ask on the past 4 weeks, has the patient had any daytime symptoms more than twice a week? Yes or no? Any nighttime awakening due to asthma? Yes or no? SABA reliever more than twice a week, and any activity limitation. And this in turn should come at the topmost corner. If there is none of these, it's well controlled, partly controlled, and uncontrolled. So supposedly, if the patient has now the patient comes to you and you say in the past 4 weeks he had daytime symptoms for around 5 days. That means it is yes. So and for 5 days, 5 days means it's 3 to 4 of this that comes under uncontrolled asthma. If he had any nighttime awakening due to asthma, even one episode, that is partly controlled. If it's more than 2 episodes, it's uncontrolled. SABA reliever for more than twice a week. So depending on that, you can grade. Sorry for this. This thing should actually come on the top. So depending on that is known as a asthma control, symptom control questionnaire. Now, what are the factors which are and there is something called as this you will find on the internet, asthma control test and asthma control questionnaire. All that is just theoretical. There is a set of questions which are to be asked, and depending on this question, you can give them particular points, and then depending on the values, like something called as 5 to 15 is a poorly controlled asthma in asthma control questionnaire. And in an asthma control test, anything greater than 1.5, it's a poorly controlled asthma. So this you can easily find it out in all the books. There's no point in memorizing all that things. Just remember the normal values, and you can make a print or copy of that. And whenever a patient comes to you, you can ask him those questions for a clinical point of view. For exam point of view, if you wanna study all that, it's okay. But in clinical point of view, you can always cross-check your questions. So risk factor for exacerbation. What are the risk factors which will point that patient have a higher chance of exacerbation? If he has a higher eosinophil count, if he has a low FEV1, smoking history, improper inhaler technique, non-compliance, and comorbidity. If you ask me what is the most important point in this which leads to a risk factor, which is a risk factor for exacerbation, it's always a improper inhaler technique and non-compliance. So always one thing to remember, even for future clinicians, is if a patient comes to you, if you have diagnosed the patient as asthma, always train him to use the inhaler. If you have if you have someone working for you and explaining it, well and good. If you have nurses are training the patient, well and good. If no one is there, it's basically your duty to train the patient on how to use the inhaler, because the patient is definitely going to come back to you and he'll be saying, you have given me so much of treatment, but nothing is working out. So treat him how to teach him how to use the inhaler properly. Tell him that it's necessary to use the inhaler. And as we know, inhalers are the mainstay of asthma. There are no oral medications which help. I mean, it's just a supportive management. In the earlier thought process of oral medications for asthma, it's no longer acceptable. It's more of an inhaler-based therapy. The next thing to always remember, always keep in mind is, uh, if he is a smoker, ask him to quit smoking. Smoking as it doesn't help, and smoking in turn, as I told, he will go into a difficult severe asthma and a difficult to treat asthma, which is very different. And always look at the high eosinophil count and low FeV even. So that we know, the more severe the obstruction, more chances of exacerbations. So that's what. So basically, I have discussed the pathogenesis of bronchial asthma, how to approach a case of bronchial asthma, what are the lab functions which has to be done. So summarizing, pathogenesis, Th2 low, Th2 high asthma. For diagnosis, you have spirometry, which is most important. Peak expiratory flow in a poor clinical setting. If nothing is providing, then you can do a bronchial challenge testing. Then you have to see the improvement after 4 months. After 4 weeks or after 2 to 3 months using the questionnaire, which I told, in which there is poorly controlled, well controlled, and moderately controlled and partly controlled asthma. So now coming to treatment of bronchial asthma. As I told, I won't be discussing every drug in detail. I'll just give a brief overview and from a clinical point of view on how to treat a case of bronchial asthma. So these are the mainstay of treatment. The mainstay of treatment, I will always say, is the inhaler corticosteroid plus LABA. According to new GINA guidelines, a steroid is always important, and the short-acting beta agonist should never be given alone. That was a mistake. It was something which came up in GINA 2018, 2019. Earlier, even our textbooks say we used to give beta agonist alone, but beta agonist should never be given alone. It should be always be combined with the inhaled corticosteroid. The mainstay, the main point here is asthma, as we know, is an inflammatory disorder. The mainstay here is anti-inflammation. So steroids are more anti-inflammatory than LABA. So the other drugs, aminophenol or derifilins, is still a question mark. According to your according to your GINA guidelines, aminophenol is not recommended even in severe exacerbation. Leukotriene receptor antagonist, that is also in a later stage as a supportive medicine. Newer biological agent, allergen immunotherapy. So this is one graph which you should always keep in mind. So whenever you are diagnosing a case of asthma, as I told, you have to assess every 2 to 3 months. Confirmation of the diagnosis. If the patient is not getting control, whether he has some other disease, symptom control and modifiable risk factors, comorbidities, inhaler technique, which is the most important according to me, whether his inhaler technique and adherence is proper, and patient preference and goals. And then is the treatment of modifiable risk factors, non-pharmacological strategies, asthma medication, whether you have to step up, step down, education and skill training, and review, and symptom exacerbations. So this is what I told. Important point, GINA no longer recommends treatment of asthma in adults and adolescents with the SABA alone. Means your Astellin is not enough. Then all adults and adolescents with asthma should receive a ICS containing controller treatment to reduce their risk of serious exacerbations and control symptoms. And ICS, so it's a combination. You can give ICS alone, low dose ICS, medium dose ICS. You can give it alone, but SABA can never be given alone. And ICS containing controller can be delivered either with regular daily treatment or in mild asthma with as needed ICS formoterol taken whenever needed for symptom relief. So whenever you are discussing about the treatment of asthma, there's something called as a reliever therapy and a maintenance therapy. Reliever therapy is the one which gives you a temporary relief. Maintenance therapy or SOS, where you see as an SOS mechanism. You have an immediate exacerbation, you take it, you get a relief, temporary relief. Maintenance therapy is one which maintains the therapy for a longer duration. That gives you a longer time of control. Something like your insulin. You have a short-acting insulin and long-acting insulin. The long-acting insulin gives you a more than a 12 to 24 hours of coverage, right? And a short-acting insulin will give you just to reduce your sugar levels for that point in time. So now earlier it used to be a reliever therapy was different, your maintenance therapy was different. Now it's something called as a smart therapy, that is single maintenance and reliever therapy. So use the same inhaler as a maintenance therapy as well as the same inhaler as a reliever therapy. So this is according to GINA 2021 guidelines. In GINA 2020, and ICS-LABA was thought of as the reliever as well as the maintenance. Here now, there's something called as a track 1 and track 2. In track 1, the important point to note here is, just remember there are two, track 1, track 2. In track 1, the reliever is as needed low dose ICS formoterol. And in track 2, the reliever is as needed SABA. So that is the only difference. In track 1, your reliever is a ICS formoterol, as we know, is a long-acting beta agonist. So it's a low-dose ICS LABA. And in track 2, the reliever is always as needed SABA. So this is what. So basically in asthma, there's nothing called as a permanent treatment. You have to always step down and step up your treatment according to the condition of the patient. So initially, you confirm the diagnosis, you treat other modifiable risk factors, you look for comorbidity, you look for inhaler technique adherence and patient preference. Then start here if. So there are two tracks, as I told, track 1 and track 2. It's entirely up to the physician whether he wants to use track 1 and track 2. In track 1, the ICS formoterol is used as a reliever, which reduces the risk of exacerbation compared with using a SABA reliever. In track 2, before considering a regimen with SABA reliever, check if the patient is regulated with daily controller therapy. So here, now step 1, ideally, although there are track 1 and track 2, it's up to the clinician. They always say that track 1 is way better than track 2. So steps 1 to 2. So in this, you leave as needed an SOS low dose ICS formoterol. This is your maintenance. And as your reliever, you always name as needed formoterol low dose ICS formoterol. So here the point is, a single inhaler is enough for the patient. He can use this as a reliever as well as a maintenance. Then now you go to step 3. In step 3, you keep a maintenance dose of ICS formoterol. That is, you have to take a dose of ICS formoterol for sure every day. And as a reliever, you can give one more dose of ICS formoterol. So here it is, you can use it whenever you want. It's like an SOS. Whenever you have symptoms, whenever you have exacerbation, you use the inhaler. That's it. Here what happens is you have symptoms on most days and you have nocturnal waking up more than 2 times a week or more than 2 times a month or once a week or more. In such cases, you use a step 3. And in step 4, if you have daily symptoms, if you see that even after giving an inhaler, the patient is not improving, what happens here is your LABA is the same. You increase the dose of steroids. So here, if it's a low dose ICS, here you make it medium dose ICS. And if it's still not controlled, what you can do is consider a high dose ICS formoterol or add on a LAMA, that is long-acting muscarinic antagonist, or refer for phenotypic evaluation. So phenotypic evaluation I'll be discussing in some time. So basically in track 1, what you have to remember is your reliever as well as the maintenance is same. It's a long-acting beta agonist plus inhaled corticosteroid, preferably formoterol containing ICS regimen. In step 1 and step 2, you use it as SOS. From step 3, you have to increase the dose of your inhaled steroid, medium dose, high dose, low dose, and medium dose. And your reliever will always remain a low dose ICS formoterol. So here in step 1 and step 2, it can be same inhaler. What happens in step 3? In step 3 also, it will be the same. Step 4, you have to increase the dose of inhaled steroid. So you'll have to take a maintenance inhaler as one with an increased dose of steroid, while your reliever will always remain the same. If it's an uncontrolled asthma, there's other investigations which you have to do. And here what happens is, in step 1, you have to give here step 1 and step 2 ICS formoterol is covered. Here in step 1, if you have symptoms less than twice a month, you can use a SABA as and when needed. And step 1, take ICS whenever SABA is taken. So whenever you are taking a SABA, then you have to take ICS again. So that means you are giving 2 inhalers to the patient. As such, patient is hesitant to use inhalers. This in turn will reduce the patient compliance even further. So here also, you have a low dose maintenance ICS, low dose ICS LABA, So from step 3, you become a ICS LABA and short-acting SABA. So initially, it's a dual inhaler and patient complaints will have to be seen. So always, as we see, it's a step up and step down. There's no single treatment for asthma. Depending on the patient symptom control and patient, depending on the exacerbations, you either increase the duration or decrease the duration. So it is always like a step-by-step process, and you can always, there is always a step down which is there. In CO, this is one of the main differences in COPD. In COPD, there is no step down as such. All right. Only in a group D COPD patients, when you are giving inhaled corticosteroid, there's an option of decreasing the or stopping the inhaled corticosteroids. That is in group D. Other than that, there is no step down because COPD is a progressive condition. Asthma, as I told, it's something which always gets exacerbated at some point in time. So this is track 1 and track 2. That's always shown in the graph. So just remember, in track 1, it's always ICS, ICS formoterol. Initially, it can be used only on an SOS basis. Later, you use a low dose ICS as a maintenance as a reliever. And step 4, you make it a medium dose ICS LABA plus a low dose ICS LABA as your reliever. So this is what happens. So this is what I already told you. So this is the same thing. So that's what. So that is one thing. So just remember, in basics of asthma treatment, you should always use an inhaler. Inhalers are your mainstay of treatment. And the inhaler don't give a SABA alone. Always give a SABA plus ICS combination. Then it's always better to use a track 1 of treatment rather than track 2, because in track 2, your inhaler number will increase. Patient compliance may reduce. So always it's better to do by a track 1. And just keep on stepping up your treatment on step 5. And now what you are seeing from those treatment guidelines is it's always the older drugs like aminophyllins are not that helpful. It's only in the later stage in step 5 you can try, but aminophylline is not at all indicated. The leukotriene receptor antagonists are indicated in step 5. It can be used as a add-on treatment. Just see this graph. There is no mention of aminophylline anywhere. So, but what is the most common drug we give? Deriphyllin and salbutamol. So, and is there any mention of oral beta agonist here? No mention. So, I understand in some places due to financial constraints, you will have to resort to treatment with theophylline and salbutamol. But according to guidelines, in nowhere mentioned aminophylline. Even in exacerbations, it's not indicated. Oral SABA, oral beta agonist are nowhere indicated. Your your LTR, the leukotriene receptor antagonist, can be tried in a uncontrolled asthma or a severe asthma, and it may be in earlier. This is something which was given in the earlier GINA guidelines. In this, you can always use a daily leukotriene receptor antagonist or low dose SABA whenever SABA is taken. So that also, it's not a mainstay of treatment. You can only try. So there's something called as allergen immunotherapy, just basics, sublingual and subcutaneous immunotherapy. So what is the important point to note here is, although there's a, what do you call, there's a hue and cry about allergen immunotherapy and everything. The studies have been done according to GINA. Studies have been done only in house dust mite and grass pollens. The latest GINA guidelines, which is coming up in 2022, has a plan to review and introduce guidelines for allergen immunotherapy. There's just a basics which I mentioned. So in subcutaneous immunotherapy, you give what happens in allergen immunotherapy is, suppose if you have a allergy to dust mite, you make a solution of that, and you give a initially you give a low dose, then you keep giving higher doses until the patient becomes tolerant at a particular dose. So administration of extracts in a progressively higher doses to induce desensitization and a tolerance, so that when the higher doses attained, the patient won't respond to. Basically, you are injecting the allergen in itself. There's always a risk of anaphylaxis which has to be taken care. It has been shown a reduction in symptom scores and medication requirement, and improved allergen specific and non-specific airway hyperresponsiveness. Then same thing with sublingual immunotherapy. You give it sublingually, and here it's only for house dust mite persistent, despite you are giving low to medium dose ICS steroids, and considering adding slit, provided FEV1 is greater than 70%. So that is basically, so immunotherapy, if someone asks you, it's only approved in studies of house dust mite and grass pollens. And main problem here is it's a very, very long therapy. because you have to understand what is the particular dose of the antigen to which you are getting tolerance. So you keep on increasing the doses, and at a particular dose you stop treatment. So that is one thing which has to be always remembered. So vaccination, influenza vaccination every year, or at least when vaccination of general population advised. Pneumococcal vaccination, although is very highly indicated in COPD, there is insufficient evidence or evidence D in, according to GINA 2021, in bronchial asthma. Then this is a newer innovation which are common, which is known as a bronchial thermoplasty. It's a newer innovation. It can be used in step 5 with an uncontrolled bronchial asthma. It is costly. Not all centers do it. Basically, what happens is you give radiation at around 60 degrees centigrade, and whatever bronchial, the thickened bronchi which are there, because of bronchial hyperresponsiveness, smooth muscle hypertrophy, whatever thickened bronchi are there, you just radiation is and destroy it. Usually done in 3 settings. One important point to note here is it's not recommended if your FEV1 is less than 60%. And according to GINA, there have been chances of recurrence as well. So, and in many studies, you can reduce the dose of steroids. Now, how useful is that? Time only will tell. Studies are still being undertaken in bronchial thermoplasty. Yeah, but it can be if you have the time, and if you have the time and money for that, and because it can be done only in higher centers. I don't think the skill come up in smaller centers, and not everyone does that. So depending on that. And vitamin D, as I told earlier, low doses of vitamin D increase frequency of exacerbation. However, there is no good quality evidence supporting the use of vitamin D, but more studies are needed. But since it's not harmful, you can always give it a go. Nutritional deficiency, as I told, is always a risk factor for bronchial asthma. Then non-pharmacological intervention, smoking cessation, weight reduction, safety precautions at workplace, healthy diet, stress reduction, avoidance of indoor air pollution, and avoidance of food products if you need. So that is the basic treatment of asthma. Now we go to the step 5, which is known as a difficult to treat asthma and severe asthma. Now, what do you mean by difficult to treat asthma? So there's something called as difficult to treat asthma and severe asthma. So this definition is important. So what you have to see here is, this is high intensity treatment. So here you are given a high dose of steroid and LABA and medium dose ICS LABA plus an oral corticosteroids. Now in this, out of this 24%, 17% are difficult to treat asthma. In this, you are given a high intensity treatment, but there is a poor symptom control. But the point here to note here is, here the poor symptom control is either due to poor inhaler use, or if he has any contributory factors which are resulting in asthma. That is obesity, smoking, or maybe an occupational exposure, maybe infections. And here, a small subset of difficult to treat asthma results in severe asthma. That is around 3.7% of difficult to treat asthma patients end up in a severe asthma. Here you have to give a high, here in spite of high intensity treatment, there's a poor symptom control in spite of good adherence and inhaler technique. So difficult to treat asthma. So it's a subset of asthma in which you are given step 5 treatment, but the patient is not responding to that treatment. That is, you are given the highest treatment, but the patient is not responding. So that is known as a difficult to treat asthma. But it does not necessarily mean a difficult patient. That means it's not that there's no treatment for that. Basically, there are some contributory factors which may be resulting in it being difficult to treat. So in such cases, that is one point to be noted. That is what is called as a difficult to treat asthma. You can either improve the inhaler technique of the patient or improve the patient adherence. So that can be helpful. Now, next is what we call as a severe asthma. Severe asthma means you are treated everything properly. You are given all the medicines. You are given an oral corticosteroid. You are given a high dose ICS LABA or ICS formoterol. Treatment contributory factors are treated, or there's no contributory factors, and it worsens when the high dose treatment is decreased. And approximately, that means whenever you are given this high, the treatment is going at a very high level, but supposedly you just reduce the treatment, the patient goes into worsening. And approximately 3 to 10% of patients with asthma have severe asthma. So as I told, whenever a patient comes and step by the treatment is not under control, the first step to assess is whether the patient is using the inhaler properly, whether there are other contributory factors like obesity, smoking, any occupational exposure. Treat that contributory factor. Even after treating the contributory factor, if the patient is not improving, that means it's a case of severe asthma. So whenever, so this is something of a more, I mean, if you have a severe asthma, what's the first thing you have to do is you have to look at the blood eosinophil count. You have to look at sputum eosinophil count. And there's something called as a FeNO, which is fractional excretion of nitric oxide. That is the amount of nitric oxide in your breath. So if the, now here is what I told, the phenotype. Here is where your interleukins come into play. The interleukins which we had discussed in initially, that is interleukin 4, 5, 13, and all those things will become useful right at this point in time when you are looking for a directed therapy. Now you are given a high dose of ICS-LABA to the patient. Your patient is also on an oral corticosteroid. Now, irrespective of all that, your patient is still not getting control. He is a case of severe asthma. So these are the investigations you should do. You take a blood eosinophil count. You took a, if you have a FeNO, do a FeNO. It's all OR. So most of the centers don't have FeNO. If possible, do a sputum eosinophil. Take a proper history, whether it's allergic driven or not, whether the patient has maintenance OCS. So now if it is yes, consider other stress, consider increasing the ICS dose. If your inhaled corticosteroid is going at a medium dose, consider stepping down the inhaled corticosteroid to a higher dose for 3 to 6 months. Now see if there is any add-on biological therapy which is available. And consider other diagnoses as well. This is also important. ABPA, chronic rhinosinusitis, nasal polyposis, atopic dermatitis. Now, always look for a type, any add-on biologicals which is available. So, here is where your typing comes. So, if in case here your eosinophil counts are less than 150 or any of these are negative, then it's not a type 2 inflammation. That is, it is not a Th2 type anymore. So it's not an allergy driven asthma. Your biologicals won't help here. So always keep in mind the pathogenesis. That is why I always discuss a pathogenesis in detail initially, because in your step 5 treatment of asthma, the pathogenesis is really, really important, and that is what brings a change. So if there is no evidence of a type 2 inflammation, review the basics. That is, look at the differential diagnosis, inhaler techniques, adherence, comorbidities, avoid exposures, consider, do an HRCT thorax, do a bronchoscopy, rule out other diagnoses because it's not allergy driven. And you can either give a trial of a long-acting muscarinic antagonist or an azithromycin, or low-dose OCS, but implement strategies to minimize side effect, and consider for bronchial thermoplasty if necessary. So, if it's not an allergic-driven therapy, always go for these things. Always rule out other diagnoses, do a bronchoscopy, do an HRCT thorax, and consider add-on treatment with a LAMA or azithromycin. Now, supposedly, if your other reports are coming as positive, that is your eosinophil count is greater than or equal to 150, your FeNO is greater than 20 parts per billion, if your sputum eosinophil count is greater than 2%, look at the other biological therapy. As we all know, anti-IgE. The IgE is one of the most important factors which was there in, pathogenesis of asthma. So consider anti-IgE treatment, which is omalizumab. Or if it's an which is the factors which support good response to anti-IgE. If your eosinophil count is more than 260, if your FeNO is more than 20 parts per billion, if it's an allergy-driven symptom, and if it's a childhood onset asthma. If no, look at an anti-interleukin 5 or anti-interleukin 5 R therapy. So what are the factors which look at the anti-interleukin 5 therapy, which shows a good predictable response? If your blood eosinophils is very high, if you are more exacerbation in previous year, if you're adult onset asthma and nasal polyposis. So in anti-IgE, when do you give? When your eosinophil count is greater than 260, if your symptoms are mainly allergy driven and you have childhood onset. Interleukin 5, you give it when you have an adult onset, whenever you have a nasal polyposis and eosinophil count is very, very high. The point here to be noted is in omalizumab, you can't, it's given, there's a particular range in which you can give. It's always between, patients is between 70 to 700. There is no doses of omalizumab beyond that. And interleukin 4R if you have a higher FeNO and higher blood eosinophil counts. Now, after that, I will be discussing the drugs in some. I'll show you a table. Now, if you find anything is positive which can predict your response, choose one if eligible and trial for at least 4 months and assess response. Now you have to see if there's a good asthma response. Yes, good response to T2 targeted therapy. Continue for trial of 6 to 12 months. If no, stop add-on therapy and look for another therapy. So you have to always keep assessing the treatment. You have to always look at other things. Now, so you have always come. Now the patient is having a refractory or underlying type 2 inflammation. This I already told in the graph. If not a type 2 phenotype, that is, you see that his eosinophil counts are not raised. His pheno is negative. His sputum eosinophil is negative. There's no allergy history, classical allergy history as such. There's no nasal polyposis. In such cases, as I told, always try adding a leukotriene receptor antagonist or a LAMA. A short course of macrolide prophylaxis, that is azithromycin 250 milligram daily for 3 months or 500 milligram alternate day. Rule out other comorbidities. Do investigation, do an HRCT thorax, do a DLCO, do a bronchoscopy, and if needed, you can always refer in for a bronchial thermoplast. So when to review? Every 3 to 6 months. If the patient is not improving on targeted therapy, do not stop the inhaler use. If the patient is now, you are suppose you have started him on anti-IgE. If the patient is improving on anti-IgE, that doesn't mean that you can stop your inhaled corticosteroids and other treatment. You have to continue your inhaled corticosteroid treatment for at least 12 months. Even if clinically improving, a medium dose ICS-LABA may still be necessary. So these are the important point to notice here is omalizumab, mepolizumab. Omalizumab is your anti-IgE. It's approved for greater than 6 years. It's anti-IgE. The frequency is every 2 to 4 weeks. Important point to note here is it's based on IgE and body weight. When do you give it? When you have a sputum eosinophilia, allergy-driven symptoms, and elevated eosinophil. Mepolizumab is what I told. It's an anti-IgE, anti-interleukin 5, approved greater than 12 years of age, very high blood eosinophil counts, nasal polyposis, and more exacerbations in the previous year. And there are other things. So just remember the names. And important point to notice here is mg per kg body weight dosing is there only for restylizumab. And the only thing which is given IV is a restylizumab. So that is one of the MCQs which can be always asked, which is given IV, restylizumab, at what dose milligram per kg. That dosing, the weight-based dosing is available for restylizumab. Omalizumab, you give it once every 2 to 4 weeks. Mepolizumab also once every month. And other thing, mostly it's once every month. And the dose of mepolizumab is 100 milligram. For omalizumab is based on the weight, but it's not per kg. It's depending on a chart which is there, which is available on the internet. So always see and always assess the response every 3 to 6 months. Don't stop your inhaled steroids or your inhaled medicines. Continue ICS-LABA properly. So that is important. Now, the last topic of discussion, what I'll be discussing is treatment of asthma exacerbation. So this is something which is most important, I feel. Like whenever a patient comes to casualty with an asthma exacerbation, what are the things which you should do? So what do you mean by exacerbation? Exacerbation is an acute or subacute worsening of symptoms. So whatever, if the patient has an increased cough, increased breathlessness, increased wheezing, that is what we call exacerbation. And sometimes what happens is many patients of bronchial asthma are diagnosed in an exacerbation. That is the first step which comes up. So what are the factors which trigger exacerbation? Viral respiratory infection, allergen exposure, food allergy, outdoor air pollution, seasonal changes, and poor adherence with inhaled corticosteroids. So now if the patient is stable, he's not coming to casualty, he's coming to your OPD. Like I have some cough, I have some breathlessness which has increased, and maybe a slight fever, wheezing is there. What are the things you should do? We should always increase the reliever frequency. Now, if he is using the reliever, if we had asked him to use only once or twice, we can increase it to 3 times. Early increase in controller as below, increase the controller and review response. Now, that's what. So what happens is whenever, so basically asthma is like a stepping up and stepping down treatment. So if the patient has a worsening of symptoms, you increase the dose. So if you are using the controller once a day, make it twice a day. If you are using the reliever, your reliever once or twice a day, make it thrice or 4 times a day. It's a short-term change unless the patient until the patient is out of that bacterial or viral infection, or until the patient improves from that allergic manifestation. If he had increased to a smoking history, or or exposure to too much of smoke, or exposure to a particular event where there was so much of cracker use or something. So in such cases, you can always, there's a short-term change. So if it's ICS formoterol, increase the frequency of your ICS formoterol. So that's what. And if needed, you can give if you feel that the symptom, that is basically on your discretion. If you feel that the symptom is very severe, you can consider giving oral steroids for severe exacerbation. And in adults, it's prednisolone 40 to 50 milligram per day, usually for 5 to 7 days. And in children, it is 1 to 2 milligram per kg per day. And because it's a short dose, it's a steroids given only for 7 days, 5 to 7 days. There's no tapering needed. Here is needed. Tapering is not needed if the OCS is prescribed for less than or equal to 2 weeks. So now the thing is, the exacerbation, this is all adult. I'm not discussing pediatric age group here. In adult, if it's a mild or moderate, there's something called as a exacerbation, which can be differentiated into mild or moderate and severe and life-threatening exacerbation. So mild to moderate exacerbation, this is the definition. He is able to talk in phrases. If it becomes severe, he talks in words. He is not even able to complete sentences. His respiratory rate is increased. Here his respiratory rate is more than 30. Axillary muscles are not used. Here is axillary muscles are in use. Pulse rate is 100 to 120 beats per minute. Pulse rate is more than 120. O2 saturation is more than, is about 90 to 94, more than 90. Here is O2 saturation less than 90. Peak expiratory flow, if it is available, is more than 50% of predicted. In severe, it's less than 50% of predicted. And in life-threatening, patient is drowsy, confused, and silent. That is basically a really, really bad patient. So just remember this table, because it's always asked, how do you classify exacerbation of asthma? So it's either mild or moderate or severe. What is different in severe? In severe, your respiratory rate is more than 30. Your heart rate is more than 120. You have use of axillary muscles or respiration. Your peak expiratory low is less than 50% of predicted. And you talk in words, and there's use of axillary muscles or respiration. So if it's a mild or moderate exacerbation, what do you give? You start with the SABA, that's your basic salbutamol. If you have an inhaler and nebulization have equal efficacy. So 4 to 10 pass from PMDI or spacer. Give prednisolone. Prednisolone oral is more studies, and according to Jinnah, oral steroid is as useful or even more useful than IV steroids. So give an oral steroid, adult 40 to 50 milligram of prednisolone, or in children 1 to 2 milligram per kg, or maximum of 40 kg. If the patient is too toxic, he is not tolerating oral, give an injection, hydrocodone, injection prednisolone, whatever injection, hydrocortisone can be given, a short acting steroid, and always target a saturation of 93 to 95. Now, in spite of this, and you have to give the Astalin or your SABA for every 20 minutes up to 1 hour. So you have to monitor the patient for 1 hour. And after 1 hour, if the patient is worsening, you have to transfer him to ICU or a higher facility. And you can give a SABA again, give steroids or everything, oxygen support. If the patient has improved, continue treatment with as needed, with SABA as needed, assess response at 1 hour. If it's improving, you can discharge the patient. And depending on other factors, look at the saturation and everything. And you can also arrange for discharge. Now, what to give on discharge? Arrange a discharge, you can give the reliever. That is whatever reliever medication you was using, continuous needed. Controlling, you can start or step up. That is, you can either make, if the controller is giving us OD, make it BD. And you can give a short course of steroids. As I told, oral steroid 40 to 50 milligram per day if adult, for a period of 5 to 7 days, no need of tapering, and follow up within 2 to 7 days. So in children, you can ask them to follow up after 1 to 2 days. Now on follow up, you have to review symptoms and signs. You have to the reliever which you had increased, you can reduce to as needed. Controller, continue higher dose for short term, at least for 1 to 2 weeks, give the controller at a higher rate, depending on the background, and check for either exacerbation, what are the causes of that risk factor, and treat any contributory factors. So basically, when all your drugs like Derifilin and all are not given as per guidelines, what we can give is, if a patient comes with exacerbation, severe breathless, just classify him into mild, moderate, or severe. Most of the patients which are will be moderate to severe. So in such cases, give a beta agonist. SABA inhaler, if you have problem giving with an inhaler, give it in a nebulizer. Give it every 20 minutes, back to back for 1 hour. After 1 hour, assess the patient. If the patient is worsening, shift him to a higher facility, shift him to an ICU. If after 1 hour the patient is showing improvement, increase his reliever frequency. That is, increase his controller frequency. If he's taking it once a day, make it twice a day. After 7 days, call in for follow-up. Keep the reliever therapy like the controller therapy increase for a period of 2 weeks. After that, you can reduce it and give a oral steroid if necessary when you are discharging in a mild to moderate exacerbation. And if it's a life-threatening, drowsy, silent, or confused, urgent transfer to ICU facility. So now this is for the severe assessment, the severe patient. Now initially you have to see whether the airway, breathing, and circulation, any of the following symptoms are there, whether he has drowsiness, whether he has confusion, or whether he has a silent chest. If any of these are there, consult ICU, start SABA, O2 support, and prepare the patient for intubation. There is no role of a non-invasive ventilation in bronchial asthma according to GINA guidelines. It's all because your spasm. If the patient is in severe, severe exacerbation, if he has a silent chest, that means that he has his complete bronchospasm, which can be relieved only after intubation, taking care of ventilation, and giving nebulization support, or giving ventilatory support basically to relieve the spasm. If he doesn't have any silent chest, drowsiness, or confusion, again classify into mild to moderate and severe and treat them. If it's severe, always go for intubation. So important point to note here is, according to GINA, NIV, non-invasive ventilation, doesn't have much of a role in bronchial asthma. It's always intubation. And inhaled corticosteroids are the mainstay of, beta agonists can be given. Inhaled corticosteroids can be given. OCS can be given. Aminophylline is not at all recommended as per GINA guidelines. Now the other drug which is commonly mentioned in textbook, magnesium sulfate. How useful? Magnesium sulfate is in exacerbation. It's not recommended for routine use in asthma exacerbation. A single gram, a 2 milligram infusion over 20 minutes can be given because it reduces hospital admissions in some patients. Adult with FEV1 of less than 25 to 30% predicted, and who fail to respond to initial treatment, like you are given SABA back to back for 1 hour, like 20 minutes, 20 minutes, 20 minutes, you are given SABA, you are given an inhaled or a IV corticosteroid, still the patient is not improved, IV corticosteroid or an oral corticosteroid, still the patient is not improving, you can consider magnesium sulfate. So that is just a single dose, 2 gram IV infusion in 100 ml NS over 20 minutes. It reduces hospital admissions in some patients. In adults with it can be used if the patient has severe bronchial asthma, if the patient is known to be, and this FEV1 is less than 25 to 30% predicted, then you can use it. And so magnesium sulfate. Aminophylline, according to GINA guidelines, no role of aminophylline. It's basically your SABA and oral or IV steroid based treatment. If the patient is severe, if the patient is drowsy, patient is silent chest, no role of NIV. Less supportive role of NIV, always consider intubation, because intubation is something, after intubation, you get control of the airway, try to relieve the spasm. Those are things which can be done. So that's all I have for discussion up to now. I hope you were able to cover, at least you were able to understand at least some basics of asthma, how to treat asthma, how to treat exacerbations of asthma, and all those stuff. So I'll be just summarizing. Basically, bronchial asthma, according to definition, as I told, its symptoms vary over time. It varies in intensity over time. It is a chronic inflammation, and basically there are two types. One is Th2 high and Th2 low. Phenotyping is important in severe asthma for treatment. Mainstay of treatment is always inhaled corticosteroid plus a LABA or a SABA. SABA should never be given alone. And treatment of exacerbation, as I told, as per the guidelines, which are the treatments which can be used. Then use of biological agents in severe asthma according to your eosinophil count, according to your pheno, according to your sputum eosinophil counts or absolute eosinophil counts, and depending on whether patient has nasal polyposis, decide on other biologicals. So that's it for today. Thank you.